In this video lecture, I am going to talk about the actions of corticosteroids that includes glucocorticoids and mineralocorticoids. To name some of the glucocorticoids, hydrocortisone, prednisolone, methylprednisolone, dexamethasone, betamethasone and paramethasone. Amongst the mineralocorticoids, aldosterone is the most potent one and fludrocortisone is another example of a mineralocorticoid. Starting off with the effects of corticosteroids on metabolism that includes carbohydrate, protein and lipid metabolism. So let's see what are the effects of corticosteroids on carbohydrate and protein metabolism. So in presence of high levels of corticosteroids, there is decreased glucose uptake by the skeletal muscle and this is due to translocation of receptors from the plasma membrane to intracellular sites. So there is decreased expression of glucose receptors on the plasma membrane of the skeletal muscle and this decreases the glucose uptake. This decreases the utilization of glucose by the peripheral tissues such as skeletal muscle and adipose tissue, leading to a rise in blood glucose levels. So the blood glucose level rises because of decreased peripheral utilization of glucose by skeletal muscle and adipose tissue. Also, the corticosteroids have catabolic actions, which means that it causes increased breakdown of muscle in the skeletal muscle, causing increased proteolysis. And this causes mobilization of amino acids and these amino acids reach the liver and the amino acids are utilized for the formation of glucose by the process of gluconeogenesis. So, gluconeogenesis forms glucose in presence of amino acids and this increases the blood glucose level. So the blood glucose level rises in presence of high level of steroids due to decreased glucose utilization by the peripheral tissues and because of increased gluconeogenesis. So the net result is hyperglycemia. So the corticosteroids worsen the glycemic control in patients with overt diabetes and it can precipitate the onset of hyperglycemia in susceptible patients. Next, we move on to the effects of glucocorticoids on lipid metabolism. In presence of high levels of glucocorticoids, which is also known as hypercorticism, also termed as Cushing's syndrome, there is dramatic redistribution of body fat, which means that there is excessive deposition of fat in the central region, in the truncal region, in the abdomen. Also, there is deposition of fat in the back of the neck and shoulder region, which is known as buffalo hump, deposition of fat in the face, which is known as moon faces. So this type of obesity is known as central obesity and this is coupled with the loss of fat in the peripheral regions with thinning of the limbs. So there is loss of fat in the peripheral regions which leads to thinning of the limbs, thinning of the extremities, while there is deposition of body fat in the central regions and this type of obesity is known as centripetal obesity. So what is the underlying reason for the preferential deposition of body fat leading to centripetal obesity? This occurs because of differences in the sensitivity of the adipocytes in the truncal and peripheral regions to insulin and other lipolytic hormones such as growth hormone, catecholamines, thyroid hormone. It is suggested that the adipocytes in the central region or truncal region are most sensitive to the actions of insulin and insulin is a lipogenic hormone which is responsible for deposition of body fat in the central region. Conversely, in the peripheral regions or in the extremities, the adipocytes are most sensitive to the lipolytic actions of hormones such as growth hormone, catecholamines and thyroid hormones. So this is responsible for lipolytic effect leading to increased release of fatty acids and loss of body fat. So increased deposition of body fat in the central region because the adipocytes being most sensitive to the actions of insulin and peripheral thinning of the limbs is due to the lipolytic actions of certain hormones such as growth hormone, catecholamines and thyroid hormones. Next, the effects of corticosteroids on water and electrolyte balance. Aldosterone is the most potent corticosteroid that is responsible for water and electrolyte balance. If you look at the regulation of corticosteroids, CRH is released from the hypothalamus which stimulates the pituitary to secrete ACTH. ACTH stimulates the adrenal cortex which consists of 3 layers, the zona glomerulosa, fasciculata and reticularis. Zona glomerulosa secretes aldosterone, fasciculata secretes glucocorticoids, and zona reticularis synthesizes and secretes androgen. It is important to keep in mind that the inner two layers of the adrenal cortex, that is zona fasciculata and reticularis, is under the control of ACTH, whereas the outer layer, that is zona glomerulosa, is under the control of renin, angiotensin, aldosterone, which regulates the secretion of aldosterone. Therefore, acute adrenocortical insufficiency due to pituitary disease decreasing the release of ACTH, which in turn decreases the secretion of glucocorticoids, leading to adrenocortical insufficiency. Whereas the electrolyte balance remains unaffected. This is because the aldosterone secretion is spared and aldosterone is under control of renin, angiotensin, aldosterone systems. Now speaking about the actions of aldosterone, which acts on the distal convoluted tubule and collecting duct, causing increased reabsorption of sodium and water and excretion of potassium and H+ ions. So the primary features of hyperaldosteronism, whether it is excessive aldosterone secretion, there is positive sodium balance, increased expansion of extracellular fluid volume, the plasma level of sodium slightly increases, and this is accompanied by a loss of potassium or hypokalemia, and also because of loss of H+ ions, there is alkalosis. So chronically excessive aldosterone secretion or hyperaldosteronism leads to hypertension because of increase in the extracellular fluid volume, and deficiency of aldosterone can lead to hypotension and vascular collapse. Next is the effects of corticosteroids on the cardiovascular system. Corticosteroids produce direct action on the heart and blood vessels. The stimulation of mineralocorticoid receptors on the heart muscles increases cardiac fibrosis. It has been suggested that patients with primary aldosteronism show increased prevalence of atrial fibrillation, stroke, myocardial infarction, and this indicates the actions of aldosterone on mineralocorticoid receptors, increasing the risk of cardiac fibrosis and cardiovascular events. Thus, spironolactone, a mineralocorticoid receptor antagonist, blocks the cardiac fibrosis by antagonizing the action of aldosterone. Also, it has been shown that glucocorticoids increase the vascular reactivity to certain vasoactive substances such as angiotensin II and catecholamines, and this increases the risk of hypertension. So prolonged use of corticosteroids or in Cushing syndrome, where there is excessive glucocorticoids in the circulation, there is increased risk of hypertension in these patients. Thus, excessive glucocorticoids and mineralocorticoids producing direct action on the heart and blood vessels increases the risk of hypertension and increases the risk of cardiovascular events. Next, let us see what are the effects of corticosteroids on skeletal muscle function. For the normal functioning of skeletal muscle, permissive concentrations of corticosteroids is necessary. So in acute adrenocortical insufficiency, where there is decreased aldosterone levels, there is decreased work capacity. So one of the important signs of acute adrenocortical insufficiency is decreased work capacity, and in patients with Addison's disease, weakness and fatigue are frequent symptoms because of aldosterone deficiency. The muscle function can also be impaired with excessive quantities of mineralocorticoids and glucocorticoids. For example, in primary aldosteronism, where there is excessive mineralocorticoids, which results in hypokalemia, and the muscle weakness is due to hypokalemia due to potassium loss. Also, it has been demonstrated that excessive glucocorticoids cause muscle wasting, and this is known as steroid myopathy. So, muscle wasting and muscle weakness can be caused by excessive glucocorticoids and mineralocorticoids. It can also occur because of deficiency. Next, we move on to the anti-inflammatory effects of glucocorticoids. The glucocorticoids inhibit inflammation in multiple ways. Firstly, the glucocorticoids inhibit phospholipase A2 enzyme, an enzyme that is responsible for the production of arachidonic acid, a precursor that is responsible for the production of prostaglandins and leukotrienes, important mediators of inflammation. So by inhibiting phospholipase A2 enzyme, prostaglandin and leukotriene production is reduced, so the inflammation is reduced. Secondly, the glucocorticoids block the production and release of cytokines such as interleukin 1, interleukin 6, tumor necrosis factor alpha and interferon gamma, and this limits the inflammatory response. Thirdly, glucocorticoids inhibit the expression of adhesion molecules such as intracellular adhesion molecule and endothelial leukocyte adhesion molecules. So reduced expression of adhesion molecules prevents or inhibits the recruitment of leukocytes to the inflammatory sites. Thirdly, glucocorticoids reduce IgE dependent release of histamine from the basophils and the mast cells, and this helps in reducing the capillary permeability. This reduces edema at the inflammatory sites and helps to reduce inflammation. Lastly, glucocorticoids modulate the expression of genes that are involved in inflammation. So they cause upregulation of the genes that are responsible for anti-inflammatory effects and downregulate the pro-inflammatory genes. So the glucocorticoid enters the cell, binds to the glucocorticoid receptor, which in turn translocates to the nucleus, induces transcription, protein synthesis, and causes upregulation of the genes that are responsible for the synthesis of anti-inflammatory protein and downregulates the pro-inflammatory genes. So in this way, by modulating gene expression, it helps to control and limit the inflammatory responses. Now let's discuss the immunosuppressive effects of glucocorticoids. Firstly, glucocorticoids inhibit T cell activation and proliferation, thereby inhibiting cell-mediated immunity. So by decreasing the production of cytokine interleukin 2, which is responsible for proliferation and function of T lymphocytes, the cell-mediated immunity is decreased, the T cell proliferation and activation is reduced. Secondly, glucocorticoids inhibit B cell function and activation, thereby reducing the production of antibodies, so they help in reducing the humoral immunity. Thirdly, glucocorticoids inhibit the function of antigen-presenting cells such as dendritic cells, macrophages, so this decreases the ability to present antigen to the T lymphocytes and thereby initiate an immune response. They also inhibit phagocytosis by the macrophages and thereby helps to limit the immune response. Next, glucocorticoids, by reducing the production of chemokines and expression of adhesion molecules, inhibit the migration of these immune cells to the inflammatory sites or the sites of infection. Next, what are the effects of glucocorticoids on calcium metabolism? In the intestine, glucocorticoids inhibit or antagonize vitamin D action. This inhibits the absorption or transport of calcium through the intestine, thus decreasing the absorption of calcium. In the kidney, glucocorticoids promote the excretion of calcium in urine. So by inhibiting the absorption of calcium in the intestine and increasing the excretion of calcium in urine, it decreases the plasma calcium level. In the bone, the glucocorticoids cause loss of bone, loss of osteoid, and this causes increased resorption of bone in the vertebra and the ribs, and also because it amplifies the action of parathyroid hormone, there is increased resorption of bone. In the parathyroid gland, glucocorticoids are known to amplify the action of parathyroid hormone, and also there is loss of osteoid, loss of bone, and there is increased resorption of bone in the vertebra, in the ribs. So glucocorticoids cause resorption of bone, causes loss of bone. So when used for prolonged period, it can cause osteoporosis and loss of bone. Next is, what are the effects of corticosteroids on circulating blood cells? Glucocorticoids increase the circulating neutrophils of polymorphonuclear leukocytes. They also increase the red blood cells and platelets in the circulation. This is because the cells are released from the bone marrow. Conversely, glucocorticoids reduce the circulating lymphocytes, monocytes, eosinophils, and basophils, and this is due to redistribution of these cells from the circulation, from the periphery to various tissues, thus decreasing their levels. Glucocorticoids also induce apoptosis of certain lymphocyte population, that is the malignant lymphocytes, which is why they are effective for the treatment of acute lymphoblastic leukemia and Hodgkin's lymphoma. Due to the cytotoxic effects of the glucocorticoids, they reduce the tumor size and enhance the efficacy of chemotherapy and radiotherapy. They also help in reducing the side effects by reducing the dose of chemotherapy and radiotherapy. Therefore, they are useful drugs when used in combination with chemotherapy or radiotherapy for the management of malignant lymphomas. Glucocorticoids also produce effects on the central nervous system. In therapeutic doses, it can produce mild euphoria, but when used for prolonged period, it can cause anxiety, restlessness, insomnia, and depression. So these are some of the actions of corticosteroids. Thank you for watching. If you find my video useful, please like and subscribe to the channel.